A very good evening to everyone. Thank you for joining on time. We are just getting a little delayed in joining. Is Balavenkat sir there? Good evening, sir.
Yeah, Vaibhavi.
Yeah.
Sir is there.
Yeah.
In fact, we had the 100 capacity. So Zoom had 100 capacity. So Dr. Hemant Sinde is missing. I was trying to get him into it, but since Bala sir's talk, everybody is filled. No worries.
I know.
Try and organize how to go about. Sir, sure. In meantime, Bala sir, can I request everyone to go on mute, please? Because this is going to be a very important meeting, and I request you all to mute. Bala sir?
Yes, sir. Dr. Zam?
Yes, sir.
There are only 86 participants. So is it live on Anaesthesia TV also?
It is live on Anaesthesia TV, sir. That's what Rahul has left a message.
So how do we tell everybody? I think Ashok.
Yeah, we will just inform once, sir.
I think we can allow Dr. Tushar Choksi and Hemant Shinde.
That's what I'm trying to do, sir. Trying to allow Hemant Shinde and Tushar Bhai. So let me, can I request few to shift into Anaesthesia live this thing, YouTube, because my inko bol raha hu yahan pe. So
there are only 84 participants, not 100.
There are 84, sir. No, for me it is showing 100. Sir.
Oh, is it?
Yeah, it is 100.
Okay.
ગુંદામાં ખાલી ઠળિયા કાઢવાના છે, સવારે કરીશું, અત્યારે નથી.
We will start in a minute, sir. Now the time is about 8:56, so we have about 4 minutes. So we have time. So in meantime, I can request, I'll somehow try and get Hemant Shinde sir and Tushar Bhai inside. Let me see. Hemant Shinde is there. I'm admitting Hemant Shinde.
Hi.
Hemant Bhai?
I am there.
Right. Good. I'll just somehow get Tushar inside.
Sure.
Good evening, Dr. Hemant.
Hi, Dr. Bala. Good to see you.
Yeah, thank you.
Sure, bhai.
We can
try karte rahiye.
In the chat box.
I'll go in the chat box. They're asking for a link for Anaesthesia TV.
Yeah, I can share the link. I'll share the link.
Yeah.
Hemant Sinde sir, we have about 3 minutes. So in meantime, I will try and get Tushar bhai in.
Not an issue. There's tremendous
Yeah,
demand
I've
because
already.
a lot of people
Yeah.
are asking for the link and all.
પાસબુક મળી પરાગ કુમાર
Hemant Sinde sir.
Yeah.
In meantime, if you have Rahul's number, the anesthesia.
Rahul. Oh, no, I don't have. No.
Dr. Azam, it's already on in the Anesthesia TV.
Oh, it's on, sir. Fantastic. Yes, sir. Thank you, sir.
Good evening, Dr. Shyam.
Hi.
Dr. Azam, can we start? It's 8:59.
Yes, sir. We can start. I'll start recording.
Recording in progress.
Hemant Sinde sir, I think you can take over and.
Okay. Good evening, everybody. Since it's 9 p.m., we are starting. This is a very, very important topic. I am Dr. Hemant Shinde. I'm a senior consultant in Mumbai in multiple hospitals, and I've been practicing for 31 years. Well, I have a pleasure and a serious duty to introduce Dr. J.Balavenkatasubramanian, who's a very, very dear friend of mine. But before that, I will take a few minutes on why we decided to come on this particular topic. The reason being, I mean, recently 3-4 days back, we've got a TCI TIVA group, and that's a WhatsApp group. There are about 800 international national members, and we were discussing some facts about a particular case, and suddenly one of the members complained that the physician whom the case was referred to optimize the patient had not done the job properly, and because of that the case got postponed, and then the floodgates opened. Everybody started commenting in various ways and their own experiences, how things have happened, and how we should not be overtly dependent on these physicians because they don't understand what an anesthesiologist is supposed to look for, and also our drugs, our complications, our physiology of the procedures which we conduct, and which that led to us, Dr. Tushar Choksi, Dr. Balavenkat, and all of us decided that let's clear the air on this particular topic. It's pretty gray because, India is not a uniformly developed country. Different people work in different surroundings, different infrastructures. There's a full-time system in government. There is a department system. There are part-time anesthesiologists. There are private practicing anesthesiologists. So everybody's perspective differs. And to answer these queries, in a topic which is extremely gray, we just thought Dr. Balavenkatasubramanian should be he should take the key role in this to clear the air completely, and let's make this into a black and white do's and don'ts, because in his hospital for the last 20 years, they have been doing this job as an anesthesiologist, as a perioperative physician. That's why this topic is very, very important. And that's why we have chosen and we have given him this topic. And I'm sure at the end of this particular topic, many of our concepts would be clear. Now I come to the next part of introducing my very, very dear friend, Dr. Balavenkat. Now, all of us, you who are from India, I'm sure you have heard his name, you have met him, you have liked him, and you have attended Ganga refresher course, AORA conferences, which he is the pillar of. But I am what I'm. If I start discussing his CV, then it would be next 20 minutes. I'll be only talking about his CV. So what I'm going to do is I'm going to come out with my take on Bala, and Bala as a personal friend, he how he's got friends across the country as well as on the international level. He's got India into international level. He calls all the guests to India in his AOR as well as the GAC conference, for which he is conducting for 9 years. He has excellent relationship with the industry, the pharma industry, and when I always think that what an ideal doctor should be, and I start remembering the qualities of an anesthesiologist or a doctor who should have ideal qualities, and I come across so many qualities which I see in Bala, and some of them are like he is highly compassionate, his empathy towards patient is known, he is highly knowledgeable, he's adaptable. Now, mind you, when Dr. Bala started his career way back in the 90s as a student from Pune in Maharashtra, then of course he went to PGI Chandigarh. Mind you, blocks were not existent at that time. We were giving blocks by anatomical landmarks. After that came the PNS and now USG, and he is one of the pioneers in both the techniques, and today he's the world leader even on giving blocks. He has started under his guidance in Ganga Hospital, which is in Coimbatore, a largest private orthopedic hospital with 32 operation theaters, all managed by anesthesiologists. They don't have physicians in the hospital. He will tell you the details about it. And that is how this topic, nobody better than him to talk about it. He's a very, very family man, divides his time equally between his job. He's extremely hardworking. He's in the OT at 6 a.m. in the morning, goes on till 11. Ganga does about 10,000 plus surgeries in a year. That makes huge contribution to 5 states in orthopedics and plastic surgeries in and around Tamil Nadu, Kerala, Andhra, Karnataka, and now even Orissa and West Bengal. He is deeply spiritual. He is associated with Sadhguru's Isha Foundation. He's also into social work in Coimbatore. He is a Rotarian for many, many years. And what do I say about his academic excellence? He is WFSA chair for scientific committees. He's conducting AORA and JRC conferences for last 9 years. I've been closely associated with, and he's a team man. Even in the Indian Society of Anaesthesiologists, he is the GC member at present, and he runs a huge department of anesthesia in Ganga Hospital. I take utter privilege in welcoming Dr. J.Balavenkatasubramanian. Ladies and gentlemen, let's hear him.
Sir, full screen, sir. Yes, sir.
My sincere thanks to Dr. Hemant Shinde for that very elaborate, humbling introduction. Thank you so much, Dr. Hemant. And my sincere thanks to Dr. Tushar Choksi, who a couple of days back said that we need a session on the role of anesthesiologists as perioperative physicians. And since we have been doing it the last 2 decades, I thought I would today share the thoughts with all of you. And I think we are truly gifted to be an anesthesiologist, because I always feel when a patient comes to a hospital, especially for surgical procedure, there are 2 things that is there in the mind of that patient. One, whether he will survive the surgery and anesthesia. And number 2, what would be the pain that is associated with the surgical procedure? More than the surgery result per se, the 2 things which haunts the mind of a person is survival and pain. This is what we could gather from an audit which we did prospectively on subsequent surgical patients in close to 300 surgical patients about a year back. With this perspective in mind, I'll start my session today. I bring to you greetings from Coimbatore, now known for the Isha Yoga Center and the Adiyogi, the largest human bust in this world. Before I go into the very essence of the topic, I think it becomes essential that as a professional and as a human being, we need to have very, very strong core values to grow. And if that is there, success is a part of each one of us. So success is all about being in the process of joyfully creating a life that reflects your highest values, your deepest beliefs, and your greatest dreams. And for an anesthesiologist, I think the greatest dream is to be recognized for the work. I think over centuries and decades, I think anesthesiologists have kept on telling that I'm behind the screen. So the greatest dream for him has been to come to the forefront. And the best way to do is to become a perioperative physician. And we need to have the deepest belief that we are capable of doing it. And we need to have very high values if these two beliefs and dreams have to come true. So I will go into the next important thought, which I always share with every single presentation. This is from Mahatria Ra. This is a part of all my presentations because I feel that each one of us have to introspect this particular statement. We may be born in a middle-class family, but we can scale such heights in our lifetime that we can cause an industrial revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered to be a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. And if this has to happen, it becomes very pertinent that we need to strategize our day. So he also says, my future comes from where my time goes, and where should my time go? For everything that you want to do, you need to have time. In a sense, we reach a point in life when time almost becomes our God. With these two opening remarks, we wanted to be a fraternity and a power to reckon among the specialities. And if that has to happen, we need to inculcate very strong work ethics, which will result because of excellent discipline that we exhibit at work. This together will make us accomplish the task of being a perioperative physician. The institutions and organizations which lead us, the Indian Society of Anaesthesiologists celebrating its Platinum Jubilee, I think the mission of each one of us should be known and to be known by our activity as perioperative physicians. And I'm also happily associated with the Academy of Regional Anesthesia of India, which just celebrated its decade of pioneering work in regional anesthesia. I also take this opportunity to welcome all of you to become an exponent in using ultrasound-guided regional block, in being part of the next national meeting, which is to be held in Pune from 1st to 4th June, and the registrations are open currently. And the recently concluded in the Ganga Anesthesia refresher course, one of the important topics we had is clinical interventions for good perioperative outcome. And we also conducted 8 workshops to enhance the skill of anesthesiologist, which will make him be a perioperative physician. And I also take this opportunity to welcome as many colleagues as possible to the World Congress of Regional Anesthesia, which happens once in 4 years. This year it's going to be in Paris in September. And also, more importantly, the World Congress of Anesthesia, which again happens once in 4 years. We are fortunate that it's going to be in Singapore in the month of March. And that's the website where you can register for the World Congress. It's very important to show the good clinical work that each one of us do to the global community by presenting our work in the global forum, and also to rub shoulders with the who's who of anesthesia in the world today. This is the largest ever congregation of anesthesiologists, which happens once in 4 years, and close to few thousand people from 148 countries attend this meeting. So I take this opportunity as a member of the Educational Committee of the World Federation of Society of Anesthesiologists and as a member of the Scientific Committee of the World Congress of Anesthesia in Singapore. I welcome as many of you as possible to be a part of the scientific deliberations. We need to consider our work to be our prayer, because everything that we experience, from the food to the cloth to the shelter, the comforts and the luxuries we enjoy, all the rewards that we get is because of the work we do. So we need to consider and revere our workplace, and our work is our prayer. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, with 38 operating theatres. It's a 650-bedded hospital. We do close to 26,000 surgeries every year. And the most important thing here I would wanted to confess and wanted to feel happy about is, since 2002, we have weaned off all the physicians from the hospital. So there are only two major branches. One is the surgical branch and the other is the anesthesia branch. Anesthesiologists are posted in the ward. They do ward rounds. Anesthesiologists look after the HDU, the intensive care, the preoperative optimization, pre-anesthetic room. So in entirety, the perioperative care is done by anesthesiologists. But then I'm very happy that the chairman, the managing director, and the two directors, Dr. Raj Sabapathy and Dr. Rajshekharan, head department of plastic surgery and head department of orthopedic surgery, allowed us to be the perioperative physicians, gave us the confidence to face the world being a perioperative physician. It doesn't mean that we can tackle every single medical issue. There are a lot of issues which are beyond us. So we have a panel of super specialists who are on call and will help us when needed. So we need to appropriately call them, because I wanted to declare that it doesn't mean that we can do everything. But I also want to declare that out of 100 medical issues, 97 of them can be easily looked after by us without having additional help. I would start with an example. So this is one of our prize cases. This was a 24-year-old young engineering student. This happened way back in 2006. As I said, we started the perioperative physician work from 2002. She was run over as she was going to the college, and she was an ASA grade 1 patient. Within seconds, she became an ASA grade 5. When she came in, she was having jaw breathing. So immediately in our institution, the protocol is class 3 and class 4 hemorrhage. Not a second is wasted in the emergency room. They're immediately shifted to the ante room of the operating theatre, which happens to be the resuscitation room. And we have kept the ECG machine, the X-ray, the ultrasound, everything in that room. So the patient doesn't go anywhere. Everything comes to the patient. So she was immediately intubated, and the injuries, as you see, it was a run-over injury. It was an open injury you see near the lower abdominal quadrant, and also she had a tense abdomen. There was no other open injuries or bleeding. So obviously she was bleeding inside. So immediately EFAST was done. Again, I wanted to emphasize, EFAST is done by the anesthesiologist. You don't give a call to the radiologist to come. So it showed that this patient had a splenic rupture. Immediately, resuscitative laparotomy was done and about massive transfusion protocol initiated. She was postoperatively ventilated for 48 hours and extubated. All this was possible if you retrospectively analyze that there was not a minute that was lost for any kind of opinion, and where the prime caregiver became the sole person who is in charge of both the assessing the patient, the skill that was needed to analyze with using the investigation modalities like ultrasound, taking the decision, and also shifting inside the operating room. The advantage of doing this has been that the minutes that were between the arrival of the patient to the table can be minimized tremendously, and this results in a life being saved. Possibly this is the reason why we became extremely popular and busy, because we didn't ask for money, we didn't waste time, and we immediately initiated the treatment. And I think now we should have to our credit several of these polytrauma patients being saved because of the proactiveness and anesthesiologist working as perioperative physician. So this hospital trauma policy and philosophy has been the one which has really helped us to grow. And we also brought in the concept of honorable block. So whether it is day or night, when the patient comes in, it's a protocol that immediately is assessed by an anesthesiologist. The internal milieu is corrected, and if needed, like the electrolyte imbalance, fluid imbalance, but at the same time, immediately a block is instituted and made them pain-free. So these two things were the way we began our journey as perioperative physician. And I think saving life and giving pain relief, we can definitely be called as the angels. And this was a letter to the editor, which was published, Anesthesiologist as a Perioperative Physician in 2017, sharing with them the possibility of an anesthesiologist being a very good perioperative physician. So now, what is perioperative medicine? Perioperative medicine, I think in the next few decades, this is going to be one of the important components of perioperative care. This is going to be a subject by itself. And I think it's not far from now this is going to happen. So perioperative medicine is a new and rapidly evolving clinical science that addresses the needs of a group of a patient population with increasingly compromised needs. So it needs an integrated multidisciplinary medical care. But from the moment you contemplate on doing a surgery to its full recovery, and this has got profound implications on the future of anesthesia practice. So creating elective surgical pathways which offer a particular opportunity to plan radical change in the way care is delivered is based on patient needs rather than provider convenience. I think this is something, an excellent statement. Based on patient need rather than the provider convenience. Like you wouldn't say that I'm very tired, so I'll do the surgery tomorrow. But if the patient needs one, now it has to be done one. This is another important factor in the perioperative care. If you don't do the perioperative care yourself, then what happens is if we ask for too many opinions, then too many cooks will spoil the broth. And one leader, if he wants the responsibility, best outcome. Having said this, we need to go and see what one of the most accomplished anesthesiologists of this century, Ronald Miller, had to say. The American Society of Anesthesiologists, they constituted a task force to identify the possible anesthesia paradigm. This was headed by Ronald Miller. They wanted to know what should be the anesthesia paradigm. And he said, anesthesiologists have to diversify their practice paradigms in order to ensure a future leadership position in medicine. And for that, they have to become perioperative physician. So perioperative care pathways is an excellent, there's an excellent article. It tells about the re-engineering care to achieve the triple aim. The triple aim of perioperative care will happen, this care pathways given by anesthesiologists starting in the preoperative period, in making sure this patient is psychologically, he is rehabilitated, nutritionally rehabilitated, and physiologically rehabilitated. This is going to be the norm in the days to come. And this is an excellent review article which talks about multimodal prehabilitation. And this is definitely going to be the one which will lead the future generation of anesthesiologists to spend a lot of time in prehabilitation for excellent postoperative outcome becomes essential when the patient is either critically ill because of the medical issues or because of the surgical challenge. And this is another very important article which talks about the quality of anesthesia. It says medicine measures, patients decide. Quality has been defined by 6 domains. The quality has to be effective. The care should be equitable. It should be timely. It should be efficient. It should be safe, and it should be patient-centered. And this is what we have to do when you are a perioperative physician. Having spoken so much, what it means to be a perioperative physician, is it enough just to have anesthetic skill? The answer is no. I think we need to gather more knowledge. If we need to become visible, it becomes important that you have to be extremely knowledgeable. Thanks to the advancements which has happened in the field of anesthesia, with the advent of super specialization, now with the advent of cardiac anesthesia, neuroanesthesia, transplant anesthesia, the anesthesiology curriculum has completely changed, and anesthesiologists now give anesthesia to patients who have significant organ dysfunction. For example, the liver transplantation in end-stage liver disease, renal transplantation in end-stage renal disease, and even lung transplantation in patients with extremely damaged lungs. So which means when an anesthesiologist is capable of anesthetizing a patient with such significant organ dysfunction, why should he be getting an opinion for slight derangement of the renal parameter or the liver parameters? So in a nutshell, if we need to become a perioperative physician, it becomes important to know about the various organ systems in the body. And if we do that very equitably, then our results are going to be excellent. Along with the knowledge, we need to enhance our skill level. Thanks to the advent of ultrasound, apart from the ultrasound-guided regional block, the other concept which is evolving and will evolve shortly is every anesthesiologist possessing the ability to use ultrasound in what we call it as point of care ultrasound, where we will be able to see the stomach and see what is there in the stomach. Is it liquid or solid? What is the volume? Then you decide to go ahead to do the case rather than waiting for 6 to 8 hours for the fasting. So fasting guidelines are going to change. If there is going to be hypoxia, we can use this tool to find out what is the cause. The primary 5 causes of the lung pathology can be detected by anesthesiologists. You put the probe on the abdomen and to see the IVC to see whether the hypotension is because of hypovolemia, or you just put the other probe and see the phased array probe, see the heart to see if there is a problem with the pumping. So this one particular tool, when that becomes a skill with the adjoining knowledge, you are going to emerge as a force to reckon within the hospital. And if we start doing evidence-based practices, if we adopt that with skill, knowledge, and evidence-based practice, our chances of having perioperative issues with our patients become very less. Now, is it enough to have good skill and knowledge alone? But more importantly, 2 more things are important. The third one is tremendous amount of honesty and integrity to the patient, and to discuss every possible perioperative issues with the patient, and tremendous humility. Just because we become perioperative physicians, we cannot challenge the surgical team. We need to be a part of the teamwork. If we have a combination of this 4 with the right attitude, we'll exceed our expectations. This is a very important case which I quote very often because it involves certain important factors and we need to introspect on this. This was one of our patients. He was a 42-year-old male, fracture dislocation of ankle with an open wound. He's a known case of systemic hypertension, diabetes, was very obese. He had coronary artery disease and angio-approved triple vessel disease. He was advised to CABG, but the patient's attendant and the patient did not want to undergo the surgery because they explained the possible complications and they decided to go for medical management. So this patient was, when he arrived, the patient was on clopidogrel 75 milligram, aspirin 75 milligram, and he had a lunch a couple of hours back and he was full stomach. So on arrival, his blood pressure was 220 by 120. his random blood sugar was 324. The heart rate was 124. Ejection fraction was 42% because of the previous myocardial injury and the coronary artery disease. Now, the reason I put this case, one of the easiest thing to do is postpone the case. We'll ask for a cardiology opinion. So we can ask for physician opinion, and we should ask for a diabetologist opinion. So we could have actually waited. But because of the strength and the power was given by the hospital to the department, and because we showed that these cases can be handled by anesthesiologist, all that we had to do was to give him a peripheral block. He was also on antiplatelets. So we went for a peripheral block. He had a popliteal approach of sciatic block. And believe me, it was a fracture dislocation ankle with excruciating pain. The single one injection in 15 minutes time could give him a complete pain relief. And within that 15 to 20 minutes of pain relief, the heart rate, which was 124, came to around 80, and the blood pressure came to around 140 by 80. So here, I just wanted to emphasize the need was to give the patient excellent pain relief in the most appropriate way. This site-specific analgesia was the best treatment for him, which was done by the anesthesiologist. And I think now we have to introspect. Had we asked for a cardiology opinion, diabetology opinion, and postponed the case, and if we have not touched the case, I just wanted to all of us to introspect that the rate pressure product would have been high. He was writhing in pain. His diastolic time would have been low. He's a known coronary artery disease. His afterload was high, and he may have had another episode of perioperative ischemia and an infarction. So this is for us to introspect. And as I'm doing that, I thought over a period of time, why anesthesiologists are fit to be perioperative physicians? Are they? Will the law agree? Now, if you introspect and if you see, this is the only specialization which during the post-graduation and during their DM read about so many other specializations which no other specialty in medical fraternity read. We read right from the physiology of a premature to a neonate to a centenarian. We deal with all the comorbidities. We read about diabetes, we read about hypertension, we read about bronchial asthma, epilepsy, Parkinsonism. You name a comorbidity, we read it. So we are the only physicians, apart from the MD General Medicine, who read so much of medicine. We are the ones who deal with multiple drugs. Our patients come with so much of polypharmacy, and you are the one who are deciphering this. You are the ones who are deciding what are the drugs that he's taking, whether to continue, not to continue, drug interactions with the drugs that you are going to use for the perioperative care. So you are the one who is going to think a lot about this and the polypharmacy and the drug interaction. You are the one who are involved in treating a critically ill patients. Majority of the ICU, 60% in Indian ICU are looked after by anesthesiologists. You're involved in trauma resuscitation. And as we discussed, we look after the end-stage organ disorder patients coming for surgical procedures. We are experts in invasive monitoring. We assess the internal milieu dynamically with our monitors. We are good in echocardiogram, eFast. We also have become masters in knowing about the coagulation profile with thromboelastography. We monitor the BIS, the flow volume loops, the ABG, near infrared spectroscopy. With the advent of ultrasound, the gastric ultrasound, RV ultrasound, we also are unique and versatile in that we are the one specialty which use the largest amount of intravenous fluid therapy in the world. We are the ones who deal with total parenteral nutrition in the world. The blood component therapy, the highest, is used by anesthesiologists. We get involved in chest physiotherapy, DVT prophylaxis, acute pain management, elective ventilation, weaning from ventilation. Now we have upscaled our skills to do percutaneous tracheostomy, intercostal drainage, bronchoscopies in the ICU. We go through the ACLS, arrhythmia management. We are in charge of the code blue in all the hospitals. And if we introspect, each one of us, if we ask us a question, is there any other specialty which does all that we do? Can anybody say that they treat so much, they encounter so many patients, and they look after the multiple medical issues? So this is a clear indication that we need to think differently, and we need to become the ones who will look after this patient as a one-stop solution inside the hospital. I'll quickly go through. If we need to accomplish this task, it's important that we take a proper preoperative assessment, very careful listening, like what an MD physician does. Every symptom that he gives has to be accounted, and based on this, we will build the plan. I call the anesthesiologist, we used to call them as a pilot, but I would like to say that we are tailors. We have to tailor make the anesthesia requirement of every single patient based on the symptoms and signs to make sure the perioperative morbidity is very less and hardly any mortality. And when you go to the pre-anesthetic assessment, this is the best place that you can show to the world who you are. And it's important that you go in a white coat. So we have made it mandatory in the hospital that the ward anesthesiologist and one in the pre-anesthetic clinic will all wear a white coat, and they would have written their name and they would have written an anesthesiologist to show the world whom we are. And when you enter, the mannerisms are so important. You have to be very calm because you're going to deal with a patient who has come for a surgical admission. His mind is so disturbed, it's chaotic. So he wants to see a very calm and comfortable doctor who's coming to see him. And you have to be confidence personified. And we have to be very effective in your communication. And we have to take the relatives into confidence, and we need to convince the patient that the perioperative period will be smooth. And believe me, this time that you spend with this patient is the best pre-medication that the patient can have. And in the process of doing this history taking, followed by an immaculate physical examination, and here I would wanted to say that we emphasize on assuring privacy, with a lot of focus on the cardiorespiratory system. We analyze the patient like what you do, like a physician does, with absolute detailing of the cardiorespiratory system, airway, spine, and where you will start the intravenous line, and if a local examination, if you plan to give a nerve block. And also now, if you think this patient needs additional help, we need to start on incentive spirometry. And if the patient is a smoker, to start on nebulization. And if the patient is alcoholic, to immediately start on thiamine supplements, 100 milligram 8th hourly. And you also ask, based upon the surgical procedure, you will call the blood bank, discuss with the surgeon, and fix for the number of blood that has to be arranged. And if it's a single unit donation, it gives an opportunity, if you're the perioperative physician, to discuss with the surgical team and the patient and ask him to donate 1 unit of blood prior to the surgery so that he need not take another blood donation. So he can use his own blood in the intraoperative period. And if the patient is polycythemic, you may have to go for a therapeutic phlebotomy. So what we need to understand is, as a perioperative physician, you're actually not optimizing or treating the chronic medical illness. It's more about correcting the physiological derangements like electrolyte balance, fluid balance, treating sepsis if it is associated in that patient, and what kind of medications you're going to continue. So this is a very important slide. It is not optimizing the chronic medical illness, but it is making the internal milieu good enough to undergo a tissue injury and a surgical procedure. And throughout the world, now medications error have become one of the commonest cause of perioperative morbidity and mortality. And when we assume the role of perioperative physician, this becomes very important, perioperative medication management. And the next important thing, all of us will be asked whether are you deemed fit to be a perioperative physician. What will happen in a court of law? For this, although everyone is familiar with informed consent, details of the process are called into question when something goes wrong. So informed consent is based on the right of patient anatomy. Every person has the right to determine what will be done to him or her, and which includes the right to consent or refuse treatment. So this is an important slide. In the role, when you play the role of perioperative physician in conjunction with the surgeon, you will explain the nature of intervention, the benefit of the intervention, the risk that is expected, and what are the available alternatives, documented, signed by you, signed by the patient, and signed by the patient attender. More important than informed consent, I personally feel lawsuits will not happen if the patient and the attendant feels that all the doctors involved were for the patient's welfare and benefit, and nowhere they felt there was negligence. Most of the times, the issues happen when we have not explained to them what to expect, or if we have done in a haste that we missed few steps, which results in several issues and complications. Those who are involved in learning through simulation now have come up with several protocols to make sure that we minimize these issues and complications. I consider this is more important than questioning the ability of an anesthesiologist. The hospital-acquired infection is the next important thing, medication error and the hospital-acquired infection. ASA grade 1 patient coming for a surgery, if he doesn't go back home in this country only, and also in the world, it's only because of two reasons. Either he got an infection or there was a medication error. And even today, even in the developed countries, these are the two factors which produce significant morbidity and mortality, and very, very important as a perioperative physician to strictly follow the protocols of hand hygiene and also taking steps for hospital-acquired infection. I'll tell you how this is important. Suppose he's continuously under you, even putting a catheter, removing the catheter, urinary catheter is with the anesthesiologist. And we don't keep the catheter even for 1 hour, that is more than required, and urosepsis can be avoided. So there is so much of good the patient gets benefited by we being a part of the process. Because we are an orthopedic unit, I will just enumerate small anecdotal studies like hip fractures we get very common. And these are the patients which produce tremendous amount of challenge. And how early we should operate? We should operate as early as possible. And several guidelines indicates the best results are done when it is done within 36 to 48 hours. These are the cases which pushed us to become perioperative physicians, because we remember when a medical physician or a cardiologist come and sees the patient, they will say, wait for 4 days, wait for 5 days, and we have to correct the internal milieu. By then, this patient's physiological parameters deteriorate, enhancing the morbidity. In fact, these are the cases which really pushed us to become perioperative physician, take up the challenge of doing these cases at the earliest and make sure that we make them survive. And over a period of time, we have learned of how to do this. So we have the things which we did to make these people live are, the minute they came, we gave them a block. Majority of them were dehydrated because they were not drinking or eating, and majority of them arrived to the hospital after 3 to 4 days after the fall, because it took a lot of time for the relatives to decide whether this 80-year-old or 90-year-old has to undergo surgery, whether he will survive surgery. So when they come in, they're already very dehydrated, pre-renal azotemia, hyponatremia. So this gave us an opportunity that when you look this patient closely, so we were able to hydrate the patient, collect the electrolytes, pre-renal azotemia could be corrected. And we also noted what is the fracture pattern, what type of surgery, whether it is going to be a hip replacement, whether it is going to be plate and screws, PFNA2. So what will be the blood loss? All these assessments can be done in the preoperative period. So holistically, you start thinking about all the facets which make us very, very comfortable in the perioperative period. So we then started going into what is the safest way to give anesthesia to these patients with multiple comorbids. So after correcting the internal milieu fast, you give the patient on arrival a block, and then the next day, when you're planning to take him for surgery, you repeat the block, and then we position him for a combined spinal epidural. And we found out that the best way the interspinal spaces open up is when they sit. And when they sit, if for the femoral block, they won't be able to sit well. So we formalize the preoperative block. initially femoral, and now we go for suprainguinal fascia iliaca or PENG block. And the most important thing that we learned is, if this patient has to survive, we have to use a combined spinal epidural, even if the surgeon says it's a 20-minute surgery, because for us, the only concern is to maintain the mean arterial pressure. And in my experience, in the last close to 3 decades of anesthesia practice, doing a lot of these hip fractures, the take-home message that I've learned is maintain the mean arterial pressure equal to the age of the patient. So if it's 90 years, do not drop the MAP less than 90. Do all the methodologies that is possible to maintain the MAP at 90. All the organs will get adequate perfusion with this. And if we have to keep the MAP equal to the age of the patient, it becomes important that you embark on a technology like the combined spinal epidural and a low dose spinal, so that you don't result in decreasing the systemic vascular resistance so much by giving very high volume. So I will complete the statement. If it's more than 100 years, we give only 0.4 to 0.5 ml of 0.5% bupivacaine heavy. Between 90 to 100, we give roughly about 0.8 to 1 ml. Between 80 to 90, about 1 to 1.2 ml. Between 70 to 80, about 1.4 ml intrathecally. It produces adequate surgical anesthesia without compromising the pressures. And we need to start with this low dose. The only thing I wanted to convey is the 2-segment regression happens within 45th minute, and we need to start substituting with 3 ml aliquots of local anesthetic solution after the 45th minute for every 20 minutes until the surgery gets over, to prolong the duration of surgical anesthesia, at the same time to maintain the mean arterial pressure. For some reason, if the mean arterial pressure drops and you need to give little fluids, and also you have to give drugs, the drug of choice, if there is tachycardia, would be phenylephrine. If there is bradycardia, it is ephedrine or mefentrine. These are the drugs which we use, hook or crook. It is important to maintain the MAP. All this you will learn because initial days when the MAP dropped, and these patients, when we had to look after them in the postoperative period with multiple organ dysfunctions, that is when we realized it is so important. If you keep your intraoperative period with comfortable MAP, postoperative complications becomes very, very less, including the delirium, the renal dysfunctions. So this is something which we learned over a period of years. And we also learned on smaller things, because when blood transfusion is given, many of them started developing temperature. So we have made it a policy now that all these patients will have only a leukodepleted Paxil. So we knew that there is going to be a problem when they use cement. So we perfected the art, the guidelines whenever they use the cement. We also perfected smaller things inside the operating room so that they don't face any issues because of this later on. One of them is hypothermia. In prolonged surgeries, it becomes a cause of coagulopathy. And when you watch this patient postoperatively, you realize all this could have been prevented if you have done things better in the intraoperative period. So we have embarked on the journey of body warming, online warming, putting the patient on mechanoprophylaxis, all long procedures. They will have the mechanoprophylaxis initiated within the theater itself. So DVT prophylaxis starts with intraoperatively itself. And when you start looking at the patient postoperatively, you yourself, then you will understand the intensity of pain and what it can produce to the patient. And with the advent of regional anesthesia, it has become very, very easy to give profound analgesia. So for us to understand the need of the postoperative analgesia, we have to see this patient. This is how we learned. Suppose we had not seen the patient at all after the immediate post-op, we wouldn't have understood the suffering of the patient. Since the department follows them closely, we understood the intensity of damage that it could do. Without analgesia, they don't eat well, they don't sleep well, they get into delirium, and because they don't eat and drink well, they go into dehydration, they go into electrolyte imbalance, they go sometimes into significant tachycardia. So we understood that it's important to make sure that in major surgical procedures, profound analgesia is very important. That's why in our major spine surgeries, for example, a major scoliosis surgery, we give a 4-quadrant erector spinae block, and it's such a joy to see the patient in the postoperative period. And when you add dexamethasone to your local anesthetic for 18 to 24 hours, you can, when the intensity of pain is the most severe, you see them extremely comfortable. And it's also important we closely monitor. So we look at the blood loss, we look at the hemodynamics, we look after the nausea, vomiting, rescue analgesia, cognitive dysfunction. So we establish protocols for every procedure. This is how we graduated when we started becoming big, more anesthesiologists. Now we are close to 84 anesthesiologists working, and they come from different parts of the country and different parts of the world. So we have to standardize our protocols. So we started standardizing our protocol. This is an example of what we do for total knee replacement. The day prior to surgery, they get 1 gram paracetamol, aceclofenac 100 milligram, pregabalin 75 milligram, alprazolam to produce good sleep, pantoprazole. So this preemptive analgesia, and they will also get an antibiotic shower to decrease the bioburden. All this we standardized, and we standardized what he gets in the 0 hour, what we use in the intraoperative period, what kind of block we use, when the patient can be ambulant. So every single factor became a component. Now, this wouldn't have been possible if the postoperative ward and the high dependency unit are also looked by multiple other specialists and intensivists, or the other cardiologist or pulmonologist, because they don't look into all this. And this gives us an opportunity to learn more and implement more. And with one, as I said, with one leader, it becomes easy to follow protocol. So we started establishing protocols for every single type of surgical procedure, and this resulted in excellent outcome. And also we start learning when we see cognitive dysfunction, then you start and go and read, because as anesthesiologists, sometimes we may not spend time in reading. Suppose if there was a delirium, we can easily ask for a neurologist opinion and keep quiet. But this is the one which results in us not learning more. So when you start reading, then you come across excellent articles like this is Perioperative Brain Health Initiative of American Society of Anesthesiologists. So it gives us an opportunity for us to read more. And this is a simple case. Throughout time immemorial, I've been told, like when there is an hyponatremia, you have to treat very slowly because it will produce central pontine myelinolysis. Here is a case, 72-year-old patient with a total knee replacement, non-hypertensive, no other comorbidities, all investigations preoperatively normal, done under combined spinal epidural, second POD, he had a seizure in the ward, a code blue was announced, and the investigation showed acute hyponatremia. This is where we learned that the new guideline to treat acute symptomatic hyponatremia is to promptly infuse 150 ml of 3% hypertonic saline intravenous over 20 minutes and consider checking the serum sodium concentration again after 20 minutes, while if it is still low, repeat it. So this is something new. I wanted all those who are attending the session to go into reading the new guideline of treating acute symptomatic hyponatremia. This is another important thing which I wanted to share with you. I just have another few slides, but this is another important slide which I want to share with you. The postoperative urinary retention of the elderly and urosepsis. Many of our total knee replacement patients, after they got discharged, they actually went into urosepsis. So quite a few we found out because of the urology clinic which is close by. They gave us a call saying that in the last 6 months, 6 patients came with urosepsis. Then we started working on it, and we found out the reason is intraoperatively, if you don't use combined spinal epidural, if the surgeon said just spinal is enough and you produce hypotension, you infuse lot of fluids, what happens in joint replacements, they don't catheterize the patient for fear of bacteremia. Many of the surgeons want them to void the urine. But in geriatric patients, when the urinary bladder capacity goes more than 500 ml, many of them develop the detrusor muscles become stretched and they become very lax. So what happens is when they urinate afterwards, the bladder does not completely collapse. Or in other words, there is more residual urine. Because of the residual urine, they go for urosepsis. So now, had we not been a perioperative physician, we wouldn't even known that it was the intrathecal drug that you use produced a urosepsis later because you gave so much fluids which was not required. You produced hypotension, you produced urinary retention, and then the damage was done. So this could have been prevented by what we did in the intraoperative period. So these are few examples to show that when we look at these patients holistically, we learn a lot. And whatever mistakes that we do intraoperatively, no other specialist knows when he sees them in the postoperative period. So only you are the best judge because you know what happened inside and you can correlate that when he develops a complication in the postoperative period. So the key message is it is very important to measure our work. Anesthesiologists should be engaged in improving all the surgical outcomes. Anesthesiologists should take more ownership of this journey, and now the patient's expectations have changed and they want more from us. So while physicians cannot eliminate the lawsuits, they can help protect themselves, providing competent and compassionate practicing good communication with the patient and the family and extremely good documentation, which will make sure that our medical decisions, when challenged, can be appropriately addressed. If we embark on this journey, our specialty will truly become iconic. And the only way to become a power to reckon iconic is to become a perioperative physician. And I think this is going to be the norm. This is going to be the future. This is what we are going to see in the decades to come. But I think the lessons that I have learned over this period is, do not equate everything to money. If you're doing a procedure, don't think we need to charge extra, because then you lose the opportunity to become better. The more you do, the more skillful you become. The more you don't do because you are not getting money for not doing something, you are the loser. Because here is a patient who has given his body for you to become an expert. And if you don't do it because you are not getting money, I think we are the losers. I think if we understand this concept and if we get aligned to a very vibrant, progressive, and ethical surgical team, we keep on expanding our responsibilities. We will keep on increasing our horizons. And we need to tell ourselves every day, we live only once, and why don't we live the fullest? And it's very important that in the process of becoming a perioperative physician, you also have to develop tremendous amount of empathy to the patient, to your substaff, to be in the operating room much ahead of time, and then make sure that there is no issues happening in the perioperative period, because like a pilot, we check everything. All these small things results in excellent competence, and we will give the best to our patients. The most important lessons are, as we grow, as a perioperative physician, we need to have tremendous integrity to the patient and the surgeon. As we become respected, more and more respected, we need to become more and more humble. We have to become more and more graceful. And as a physician, perioperatively, you need to be available and approachable all the time. I think if we incorporate all this, we as a generation will be the change, and we will have to treat every single patient as our kith and kin. With this in mind, if we keep working, we are going to see a generation of young anesthesiologists, highly respected, highly needed, who will lead a legendary life. And throughout the world, anesthesia will become one of the most preferred specialties, because it is the one which has got the power to prevent pain and the power to prevent death. Thank you so much for your patient hearing. And I hope I shared what I have gathered over the last three decades working, and the challenges that we took in converting our unit into anesthesiologists as perioperative physicians. Thank you so much.
Thank you, Dr. Balavenkat. That was a most lucid presentation. I am really happy that you could make time in your busy schedule and clear our doubts. Some of the people have asked a few questions. One of them has said that how much feasible is it to put epidural in geriatric patient? Do you face difficulties, Bala sir, in geriatric patients to put in because you said every time you put in a CSE?
Yes, the point is very important. And what solutions are? The reason why it is tough is degeneration happens in all the parts of the body. And degeneration happens in the spine too. And in India, another movement has to start now, and that movement is preventing osteoporosis. Many of the geriatric patients in this country do not see the sun at all. They all are completely confined. I would wanted this to be taken into account for even our own parents, our own elders who don't come outside, they don't do physical exercise, they're not exposed to this. So they become very osteoporotic. And this is the reason why the spine also becomes very osteoporotic. And in the process, they develop a degenerating scoliosis. So it becomes very difficult. There is a small rotation that happens. So the answer to this question is there are two possibilities. One, if the institution has got an ultrasound, we can use it to find out the posterior complex. But this may not be the case in all the institutions. So the clue is the L4, L5 and the L5S1 are not part of the scoliosis in a degenerative spine. So this becomes the place where you can insert your neuraxial one. You will always be successful. So go to the lowermost area. L2-3 is the one which are commonly affected by the degenerative scoliosis. So there is not much rotation in the vertebral body at L4-5 or L5S1.
Great. And there's one more person who's asking, I know you made it very clear in your presentation, according to the age groups, you decide the spinal dosages. Somebody wanted you to repeat it. And also you said 3 ml aliquids at every 20 minutes. She wanted to know what percentage of bupivacaine or whatever drug you are using.
Okay. So actually, this is one of the biggest learnings I've had in my lifetime of giving the low dose. For the specific reason is maintaining the mean arterial pressure, not giving too much of IV fluids, not giving atropine, not giving glycopyrrolate, not giving phenylephrine, not giving ephedrine, creating a polypharmacy and making the variables increased in already comorbid patients. So the best is to prevent all that. And the way we do it, as I said, above the age of 100. Now you get a lot of patients over the age of 100 coming for hip fractures. And I said we'll give roughly between 0.4 to 0.6 ml of 0.5% bupivacaine heavy. And now we have ropivacaine or levobupivacaine. This can be given, but the volume is, whether it is any of these three, it's about 0.5 to 0.6 ml. If it's between 90 to 100, we go about 0.8 ml. Between 80 to 90, we go for about 1 to 1.2 ml. Between 70 to 80, it's about 1.4 to 1.6 ml. So that's the maximum dose. So what happens why should you give that minimum dose? Number one, the amount of circulating CSF volume is very less. So this volume is sufficient enough to produce a good surgical anesthesia until D10. And the number of receptors which this local anesthetic have to go and block are also very less. There is an extrapolation. If someone lives for 140 years, there will be no neurons. You can do a surgery without spinal anesthesia. So the number of neurons decrease drastically. So this is another reason why it's enough if you give a very low dose. And also because of the degeneration, the whole epidural space and the neuraxial space become like a small capillary, and the capillary effect is there. Even if you keep one drop, it just ascends up. So these are the various reasons why we don't give high volume. Now, having said that, you achieve a block until D10, but this is good for 45 minutes. Then what happens, because you gave a smaller volume, regression starts taking place faster. So spinal anesthesia is usually quantified as 2-segment regression. So 2-segment regression starts happening in the 45th minute after you gave the spinal. So at the 45th minute, you start giving, each lumbar segment needs about 1.5 ml of local anesthetic. So 2-segment regressed. So now you substitute epidurally 3 ml of 0.5% bupivacaine because you want surgical anesthesia, not analgesia. So until the surgery is there, for every 20 minutes, you keep giving 0.5% bupivacaine or 0.75% ropivacaine. One of the two to produce surgical anesthesia until the surgery is there. By this process, you will just love to see the monitor. There is no alarm. The map is stable. No need to rush in fluids. No need to give any other drugs to maintain your hemodynamics.
And typically, how much IV fluids you end up giving to such patients?
Actually, in a total knee replacement, for example, if they come in, all that we need to give is 250 to 500 ml maximum. And then you allow them to take oral liquids within 2 hours. So, because most of the time it's done under tourniquet, there's no need to give so much fluid, except if they've started for a long time. You just have to give those maintenance fluid and nothing more than that.
Excellent. Bala sir, I also wanted to know what sort of, you said you all are giving femoral blocks to practically each and every patient. So are you all giving anatomical blocks or surface blocks, or you're using PNS, or you're using USG guided for these femoral blocks?
In 1998 to 2002, it was landmark. 2002 onwards to 2007 was peripheral nerve stimulator. Now 2007 until now, it is all ultrasound. So we have graduated over a period of time, and now we use only ultrasound.
And which drugs you end up using, and what dosages?
The drug that we use is, many people like ropivacaine. They think it's very cardiostable, though the volume that you use, about 15 to 20 ml, either bupivacaine or ropivacaine, actually there is no real difference. But for the safety profile, either you can use 0.25% bupivacaine or 0.2% ropin. And the 3 blocks that we use for hip fracture is either suprainguinal fascia iliaca, or the PENG block, or the femoral block with lateral femoral cutaneous nerve. So the volume that you give is approximately 15 to 20 ml with this concentration.
Great. And then in the epidural, how do you continue in the post-op analgesia?
Yeah, in case if the patient is catheterized and you're not worried about the postoperative urinary retention, which happens with continuing the epidural catheter. So one of the important component when you decide to put an epidural infusion, this patient's bladder has to be catheterized. Otherwise, we know now he will develop a urosepsis later. So in this, we use elastomeric infusion pumps because with elastomeric infusion pumps, we send this patient back to the ward. We don't keep them just because this infusion is going. We don't keep them in the postoperative ward. And multifusers are available. 4 companies produce elastomeric pumps. So you can use it right from 2 ml, 4 ml, 6 ml, 8 ml, 10 ml, 12 ml, based on the number of segments that you need to get blocked. So you will adjust accordingly. For hip fractures, most of the time, you will need 6 ml of, we use either 0.2% ropin or 0.125% bupivacaine at about 6 ml per hour.
Okay. And in your institute, you all are doing bilateral TKRs or unilateral TKRs? And if at all, what sort of post-op analgesia you all are practicing?
For me, if given an option, if it is for my mother, because always the standards are different. If it's for you, it is different. If it was a patient, it is different. So suppose if it was for me or if it was for my mother, I will try to go only for a unilateral TKR. Many people say that there's no harm in doing a bilateral TKR, but invariably, what I have seen, the discomfort levels are extremely high. If you do on one side, and the spine is also degenerated in most of this patient, it's so difficult for them to lie on the back. They want to come over to one side, right lateral or left lateral. When you do a bilateral TKR, they find it so difficult to ride supine, either right lateral or left lateral. So first, discomfort. Second, the amount of cement used is more, and the possibility of subclinical hypoxemia increases. The total amount of blood loss is more. And when they rehabilitate, when you do one knee and go for the other knee, we do it after 5 days. What happens is when they start, we ambulate immediately the next day itself. So when they ambulate, when one knee is paining, they are taking the load on the other knee. But when you do both the knees, then it becomes difficult. Now we can say we are giving regional anesthesia, bilateral blocks. Answer is yes, you can do that. But then the pain relief that is produced, we use a dual subsartorial plexus block. The pain relief is excellent. But then when both the knees are involved, their ability to ambulate becomes difficult for them. So for considering all these small issues, I would prefer a unilateral TKR. But sometimes in very young people who come for rheumatoid arthritis and they come for a bilateral knee, they don't have leave, they come with so many issues. Occasionally we do, but given an option, I would prefer a unilateral knee at a time.
Great answer. And Dr. Bala, I will also recently I was reading, there's a paper, I think ASA recent journal, American journal, it said that whether you do it, a hip fracture especially, you can do it under spinal or under general anesthesia. According to them, the results are pretty much same. I mean, what's your take since you do so much orthopedic? You all are doing hips under GA, if at all?
Not in my memory, actually. Oh. So what the take is like this. Now, that brain health initiative, I wanted all of us to go through that. I also want to know neurocognition and general anesthetic and sedatives in geriatrics, so that we need to read a lot. And when you go for site-specific analgesia without using any conscious sedation, so I don't prefer, when I do a combined spinal epidural, I don't want any conscious sedation to the patient, or in other words, minimizing opioids and sedatives for the patient. So here is an opportunity for us to read more about these drugs and its effect on the cognition in already deteriorating neurocognition. However, having said this, the literature says that there is no major difference between general anesthetic and regional anesthesia. In India, we have to take it with a pinch of salt because the amount of postoperative care, including the immediate care, availability of a very qualified nurse, one-to-one monitor, one-to-one multi-parameter monitor. If we have one, and the staff is qualified with all complications, including patient having desaturation or postoperative nausea, vomiting, then possibly the immediate possible complications are less. But in the absence of that, we would want to have a conscious patient who can take care of himself, or the airway is taken care. I would feel in our scenario, I would feel regional anesthesia has got an edge over general anesthesia.
Okay. Now there is Vashali Kenya. She's yes.
Dr. Bala, very nice to have this presentation. Almost 600 people are watching this in Facebook, YouTube, and Anaesthesia TV. On behalf of everybody, I want to ask you one question. Can we are protected in the court of law if the anesthetist alone works as a perioperative physician without any specialty consultation? If some mishap occurs in perioperative period, especially in private practice, it is very common.
I think number one, it's a very important question. And what I said all this time, the last 1 hour, was the possibilities, like the possibilities of and the ability to do it. But there are limitations in private practice because you yourself are not available later for the continuum of care. So at this point of time, the perioperative care as a physician by an anesthesiologist is possible only if we have someone in-house the 24 hours. I think only then we will be able to substantiate what I spoke now. But if we don't see the patient or there is no anesthesiologist available inside the hospital, especially in the small private hospitals, then definitely it would be very difficult, because when there is a crisis, when there is no anesthesiologist available to take care, then it becomes a problem. Then it goes to the court of law. Then they will ask why a cardiologist didn't see, why a pulmonologist didn't see. But currently, I think all those institutions which have got anesthesiologists in-house can embark on this journey.
Thank you.
In your institute, Bara, have you ever faced any such issues?
So far, no. Actually, not considering a touch wood, and thank God. I find, and I also think, if we are very clear with the patient and the patient attendant, and if you speak yourself, here in our institution, the anesthetist speaks, especially if they're critically ill. and all the possible complications are explained to the patient even before we take for surgery. And this is one important aspect. Second important aspect is, at no point of time the patient attendant should feel that patient was not attended to when it was needed. I think this is more important than any kind of opinion. And because today the session was there, I also spoke to a few medical legal experts who are anesthesiologists, Dr. Shivakumar Kombar, and because they all do a lot of work. I asked him, sir, have you ever faced? He said the most important thing is the attitude of the physician more important than his specialty. And if he has got the right attitude, no case will be there against him.
Excellent. That, I think that is it. Tushar, anything you want to add?
That is a take-home message that we can be protected in the court of law. We are working as a perioperative physician.
Yes.
What Bala sir, sorry, in reference to the same question what Tushar and Hemant Shinde sir was discussing, there were a couple of messages that says that when we have an in-house physician, and it has come to a couple of cases in the past that court has been asked that when you have the opportunity of a physician in the hospital, why not take a reference from him rather than treating yourself? So,
no, the answer to the question is there is no harm in taking a physician's opinion when it's a multi-specialty hospital. There is a physician available. You can definitely get an opinion. But my concern is the minute you start getting an opinion, you stop thinking. You stop growing. You stop learning. And this is the problem. So if our specialty has to grow, you have to take the onus. And after some time, you will understand and realize that you are much better than the physician whom you called. I want that to happen to anesthesia. We have to think differently. But at this initial phase, there's no problem in getting an opinion. If he concurs with you, it's good. If he doesn't concur with you, the problem starts. Ego starts. Then neither you look after the patient nor he looks after the patient. He starts one antibiotic, you start one antibiotic. And which antibiotic finally has to go to the patient, you don't know. Then what happens? Then you lose interest. So in other words, I would wanted to say, majority of the problems, when it becomes a perioperative care, will be under the anesthesiologist. And if he thinks that it's beyond him or he does not understand the illness, absolutely no harm or no ego in getting the opinion of another expert.
Dr. Bala, what we are facing in private institute, that surgeon himself are calling physician to take their opinion for the surgical or anesthesia, and they write in their note that patient can be taken with the due risk of anesthesia. So at that time, we know that they don't know the details of the patient as far as the intubation is concerned, the anesthesia drug is concerned, everything. So in that part, anesthetics should be, what you told is a bottom line, that anesthesiologist should be act as a perioperative physician, and we should take the only advice of this physician where the other systems are affected.
So this is directly related to the degree of confidence that the surgeon has got in his anesthesiologist and the ability of the anesthesiologist to upscale his knowledge and skill. So when you are able to detect something, like if you're as good as a cardiologist in detecting an arrhythmia and starting a medication for that, and you see that arrhythmia getting reverted, 10 times your surgeon sees, then he will know that you're equally competent to do what it is. The problem comes only when we don't rise up to the challenges. Only then he has got, only then he becomes scared. So in other words, like what I'm trying to really talk is this is not a high-headed egoistic talk. This is the talk which emphasizes the point, this specialty has to think differently. This specialty has to move forward. This specialty has to be visible. And if this all has to happen, we have to upscale everything, the knowledge and the skill. It's just not a question of whether to get an opinion or not. It's a question of making ourselves as competent as the other person, because we are and we can.
Yes.
Sir, I want to share one thing, sir. As Bala sir said, we were there round the clock in our hospital, Guntur, under the guidance of Hanumantrao sir, who is from Manipal KMC. So we are the one we used to put ICDs and all. And for me, once I have put ICD that passed through the lung parenchyma. I was in a, but the patient was survived, around 20 years patient with latter found to be having a carinal growth, so spontaneous pneumothorax bilateral. But I want to remove that, ICD, but just waiting till to inform to sir and remove the ICD. But sir has come and told me that if that was not placed, we would have gone at that same time. And it is very difficult to pass the ICD into the lung parenchyma. But the report is true. That is given by PJ Chandigarh radiologist. We are confident on his report. We have sent the patient to the NIMS with the same, with ICD in situ, though that is a report says that it is in a wrong place. But nothing happened to us. As sir says, our attitude, our commitment to the patient is most important, sir. And one more thing, we used to take opinions from the physicians, but totally we shouldn't depend on them. They comes and sees only one system, but we know to which drug the patient responds. We are following him for 24 hours. So we used to call physicians, but we will decide whether to give the drug or not, sir. But we do take their opinions. That's it. Final opinion is to give it or not is in our hands. But that will happen only when 24-hour coverage is there in the by the anesthesiologist. Thank you, sir. Thank you, Bala, sir.
Thank you, madam. Thank you so much for that insight. And I think because 10 years down the line, if all of us recollect, this evening probably will be an evening to remember, because we'll say those days we used to talk about whether anesthetists can be perioperative physicians. So 10 years down the line, all of them will say, oh, you never saw the patient pre-op and post-op? Oh, was it the norm earlier days? So this will become historical, and I wish it becomes historical.
Yeah, we all wish it that way. I think, Tushar, anything else is remaining?
Bas, that's all. And now for the thanks note, I am very thankful to Dr. Azam allowing us to give his Zoom link, Dr. Hemant Shinde for moderating the session, and of course, Dr. Balavenkat, 3 cheers to you because of the so many people and so many Facebook and this WhatsApp group were discussing about the anesthesiologist and physicians reference and perioperative physicians as an anesthesiologist. But I thought in my personal mind that we should have one good lecture by you, because I have heard this lecture before also.
Yes.
So thankful to all the listeners. And I think this was the biggest webinar I have attended in my lifetime. That was more than 600 people from across the 10 countries are attending in Facebook or YouTube, Anaesthesia link. And even I was not able to log in.
I know we were having difficulty
in the waiting room.
Azam had to let us in.
People, more than 200 people have joined immediately on the Zoom link. So thank you all, and thank you, Dr. Balavenkat. And that will be a good part. We will listen to, we will again listen to you in another topic within soon.
Yes.
Thank you. Thank you so much. Thanks, Dr. Hemant, for moderating the session well, and Dr. Azam for giving us the facility. I think we need to move together. Yes, sir?
Yes, sir. Bharat wants to say, Dr. Bharat in Naik.
Yeah. Dr. Tushar, I'm very happy. It was an excellent talk by Dr. Balavenkat, sir, as usual.
Yes, sir.
But I just wanted one question. I wanted to ask him one question.
Go ahead, sir.
Pre-operative, before spinal pain relief, out of the three, what does he prefer? It is a PANG block or FICB or femoral block?
Sir, if I tell the truth, the person, whichever one which is very confident and he can do it properly, all the three are equally good, but provided you deposit the drug exactly well. Femoral block is the easiest because you see the femoral nerve and give. The superficial fascia, the suprainguinal fascia, iliaca and PING, they're also easy, but it needs slightly more competence to do that. And I would prefer the beginners to either use femoral or suprainguinal fascia iliaca. The PING block, the problem is the viscera are close by. And if you don't see the needle properly, you may injure certain structures. So in level of the pain relief, almost all the three are equally good, sir.
But sir, you call FICB with a different name, fascia iliaca compartment block?
No, actually, fascia iliaca block is divided into suprainguinal fascia iliaca and yeah. So there's a small variation in where you deposit the drugs.
So something you give in inguinal groove is suprainguinal?
Yeah, just above that, sir. This can be done only with the help of an ultrasound. Yeah.
Okay.
Bala sir, there was one.
Thank you, sir.
Thank you, sir. So, Bala sir, if you don't mind, there is one question. Can we take by Dr.
Yeah, Azam, go.
Rajesh Casey, what he says is, how about the optimization in a daycare surgery? Because patients, come on the day of the surgery. They don't want to come a night before. So, how do you go about in your institution?
No, it's very simple. The minute a patient is decided to go to anesthesia, is immediately come to the pre-anesthetic clinic, because he sees the surgeon. Then immediately next thing he sees the pre-anesthetic clinic. So optimization happens at home, and when he comes in, he's fully optimized. So in other words, all the daycare patients are seen in the anesthetic clinic the day they decide to go for surgery, and you start the process of optimization from then on. For example, starting on iron supplement and folic acid if it's decided to go to anesthesia, immediately come to the pre-anesthetic clinic. So daycare surgeries have to be worked up earlier to optimize them.
Thank you, sir. I think.
I think we'll call it a night. It was an excellent presentation.
Hello.
Yes, Tushar bhai. Yes, someone wants to ask, but yes, I think we'll end.
Sir, Bala sir, it was such a nice, Dr. Naveen. It was such a nice, informative talk. So Bala sir, I wanted to add one thing is that you have told as a perioperative physician, really, the starting of the lecture, what you have told, your management has supported about being you as a perioperative physician. And what I have been doing, I am in a corporate hospital working in Delhi, and I have been realizing that you have to talk to your surgeon, you have to talk to your patient. It is a long process. It takes time. It doesn't happen in a single day or a few days that your confidence is gained by the physician or a surgeon. If you are showing interest, they will also show interest in you. So it is a process. We have to go through that. And if once we have become confident enough, or the surgeon has become confident in you, then the decisions taken by you nobody will challenge your decision.
Yeah, completely agree, Dr. Naveen. It's a process of understanding. It's almost like a marriage. The first year and 20 years later, you are different because you understand each other's positives and negatives, and you become flexible, and marriage works. Similarly, here again, there is over a period of time, the respect is earned, and we understand each other better.
Yeah, so I do talk to my surgeons, and they call me. If I were even at home, they give me a call. Naveen, this is a problem. Kindly send somebody to see the problem. First of all, they will call me, and then they will call a physician or a surgeon or a cardiologist or anybody else. Yeah, you just see once, you send somebody, and because we keep on talking about patients. So that's the confidence we have gained after, I think, 10 years of my practice in anesthesia.
At least, congratulations, Dr. Naveen.
It's excellent.
These are all
That's the way to go. Way to go.
To involve yourself.
To reach at your level, Bala sir, it will take us a long time. But yes,
30
we are
years.
trying enough. Yeah, 30 years.
Yeah, you're right. I mean, you're already there because you're only 1/3 of my time. Like we are 30 years and you're 10 years.
My ortho surgeon has a complaint that you have made your specialty as a principal and orthopedics as a secondary, because that is the importance you give to anesthesia and instruct staff. But that is his complaint.
Sir, I would like to share one of the incidents. If time permits, I can share one of my incidents.
Yes, sir. Go ahead. Last one.
Yeah, sir. There was this is not an ortho case. There was one gynae onco case. I have done a PAC. He was a doctor. The patient was a doctor. So I did his PAC, pre-anesthetic checkup, and I explained everything, pros and cons, and everything was done. On the day of the surgery, I was about to reach the hospital. My HOD called me, Naveen, is this patient related to you? I said, which patient, sir? This is the name of this patient for taking for the surgery. And they are saying that if there will be Dr. Naveen in the OT, then only we will go to the operation theater. So I said, no, sir, I don't know the patient. So they are saying, but you, and my HOD of the gynae onco called me. Naveen, is this patient related to you? No, sir, no, ma'am, this is patient. But they are refusing to go under anesthesia till the time you are in the operation theater. So I reached the OT OR and now I talked to the patient. Patient was the same doctor and said, oh, Dr. Naveen, now I am in a safe hand. You are there. I am in a safe hand. Now you can do whatever you want to do. And I told them this patient is not related to me, but yes, I have done a PAC of this patient. I talked to the patient for quite half an hour. Half an hour I have spoken to this patient and I cleared all his doubts, and then only they have a confidence in me.
Excellent, sir.
Fantastic.
Can we stop this hour now?
Yes.
Bala sir, not trouble, Bala sir, I guess.
Yeah, it's 10:30 almost. It went on for 1.5 hours. I think he has cleared all the doubts. Thank you very much once again, Dr. Bala.
Thank you all, Tushar, Bala sir, Hemant bhai.
Thank you, sir. Thank you for your excellent speech, sir.
Thank you, everyone.
And
Yeah,
good
thank you so
night.
much.
Stopped.
Thank you. Thank you. Thanks a lot. Good night to all.
Good night to all. Bye.
Yeah.
Good night.
Bye.
Thank you. Thank you, Azam and everybody.
Thank you, sir.
Thank you, Sunil sir. Bye-bye. Good night. Good night, Bala sir.
Good night. Good night, Azam. Thank you.
Thank you, sir.